good afternoon or late afternoon to all the ladies and gentlemen. I am happy to be the convener, not the chairman, for this session. I call upon my panelists. Mr. Vishal Gupta from Cisco was supposed to be there, but he is scheduled to go now on an urgent work, so he has deputed his colleague. I request the Cisco representative. Savita, Miss Savita, please. I request Professor S.K. Mishra, Saroj Kant Mishra from SGPGI, Lucknow. I request Mr. Girish Kumar from HP, India. Mr. Sujit Chatterjee. Mr. Sanjeev Chowdhury from Religare. Mr. Abhay Singhvi from Narayan Hrudayalaya is here. He will join soon. Okay, we'll get that. Okay, as you have been briefed already or seen the schedule, this is an industry roundtable on bridging the divide and PPP for success of telehealth, and the issue is basically how to move ahead and how to take the telehealth to the nook and corner of India and make it ubiquitously available. The mode of the conduct of this session is initially I will give the opening remarks and status of the situation and the issues to be discussed, and each of my esteemed panelists will give their individual opinions, and after that we will get into an interactive session. It is more of a collaborative discussions rather than presentations and a monotonous PowerPoint presentations. So just to give an overview, we know in India there was a formal education right from the medicine from the times of Charaka and Susruta. It is not unknown. And afterwards, we have seen in recent times, India has seen more and marvelous developments in IT, communication, and all the services segment. It was in the year 2001, most of you as may be aware, when ISRO has pioneered the concept of telemedicine, roped in so many active partners of the DIT, SGPGI, Apollo Hospital, Narayan Hrudayalaya, Amrita Institute, Shankar Netralaya, Arvind Eye Hospital, and many more. So many state governments, insurance agencies, and the vendor agencies were part of this success story, if we can call it as a success story of ISRO's network. Why I wish and proud to be say as a success story, but at the same time hesitate is, it has reached 400 nodes as of last year, but still that is not enough to reach the real grassroots of this country. So by now on the second day of this conference, we have seen the rising cost of the healthcare delivery for governments is one of the movers or the seekers for the telemedicine solution. And it also equally applies to India as anywhere in the world. And decades of work and heaps of money may not fill this gap by a brick and mortar solution of the infrastructure of setting up the hospitals in the villages or recruiting the doctors and retaining them. So the ultimate solution, by now we have come to the conclusion, is the infrastructure in the form of telemedicine or e-health or whatever is the name we may wish to call. But then the issue is telemedicine technology versus the business case. We all have seen there are so many vendors, and this year is the path-breaking event with 40 of the vendors or 40 of the industry people taking up the paid exhibition stalls and showcasing their technologies, solutions, hardware or consultancy, whatever it is. But the case is the technology versus the business case to meet the requirements as well as to make a cost-effective returns on the investment. So we can say in a way last 2 days or maybe tomorrow, this is all showcasing successfully the technologies and pilot phases as morning president was telling. But it is all like window shopping. When is the real shopping happening and where is the real billing happening? That is the end of the road which we have to see to declare really it as a successful venture or a successful program. We also know the decision to implement a telemedicine system must be based upon the business case which supports expenditure by realizing the cost savings through prudent selection of technology and the medical business practices. Somehow there is a stigma in the society, maybe in India or other places also, whenever we say business in healthcare, some negative connotation is attached. But definitely that is not the real scenario. Most of you must have seen, how many of you have gone to the post offices? Can you raise your hands? Okay. And how many of you have gone to the railway reservation counters? Okay, now last 3 years internet is there, but physical counters. Okay. How many of you have seen the money order forms thrown on the floor of any post office? 0. How many reservation forms are thrown on the floor? Some numbers? Okay. So that speaks volumes about the need for a business case. Money order form is priced 25 paise. Today you will not get even the coin if you want. 25 paise, but that is used very judiciously and very purposefully. People will carry a pencil and an eraser, write the form, fill in, then do apply the pen. In the railway reservation, it is just thrown. So the message is, there has to be a money attached if you want to attach a value to that, for the people to own it and then take care of that. That applies to a 25 paisa money order form, to a 2.5 lakhs medical equipment, or a free satellite connectivity provided, or any other software provided by any funding agency as a charity. So that is the message. So seeing that in that background, so today we are going to discuss, definitely a no solution can come across the table in a matter of half an hour or 1 hour, but we are going to deliberate on the issues like connectivity, the cost and availability, and how to scale up the successful solutions. We have had so many individual pockets of successful pilot projects, and what is required? Is it a change of mindset? If so, who has to instigate and who has to mentor to lead to the mindset? And finding the middle ground between the charity or juicing all the money in a private model, and what should be the role of the government and private sectors and the medical fraternity to take this ahead, and how private practitioners and NGOs, today we see there are so many private practitioners or individual physicians and NGOs who are enthusiastic and who want to participate in this mammoth program or project, but still they don't know how to join or how to make a wild entry into this big project of the India. And how telemedicine can be taken to the successful business model. That is the basic issue in front of us. And how to integrate it into the mainstream of healthcare delivery. Because as people have told repeatedly in the last 2 days, telemedicine should not be focused as a separate entity on its own. It is just a mechanism or a method of delivering the healthcare services. E-health or telemedicine, whatever we call, is only one of the solutions. So we thought PPP, a public-private partnership, is one of the models to take it forward, or we may come up with something else which may be much better than PPP. There is no bar on discussing beyond PPP. So is there anything else? If at all we conclude that PPP is a good model, how to implement, what are the roles and responsibilities? If we can come up with some suggestions, that is good enough to do a justice to this panel. So with that background, I now invite our panelists who are drawn from different sectors, a private hospital, a corporate hospital, and a different solution provider and a services provider. we have so many other stalwarts who have implemented telemedicine in this hall and in the other halls. But we just try to pull up new blood or new people to come up with some out-of-box solution, which probably other stalwarts might have forgotten or might not have thought in a new dimensions. That is the idea of this panelist. So these are many stalwarts, as I mentioned. So let us now start the discussion with a brief introduction and presentation by each of the panelists. As mentioned, this is not having any PowerPoint presentations, but they will focus mostly about what they have done or what are the experiences and what they feel are the ideal solutions to tackle this problem. The problem is how to make telehealth or telemedicine as a mainstream of healthcare delivery, how to integrate. Thank you.
Hi, I'm Savita Kini. I'm from Cisco. I'm a global marketing lead for our healthcare solution, which we are showcasing here at this conference. I kind of jumped into this last minute, so I'm just going to try to collect a few thoughts together. First of all, I want to just give a quick examples of what Cisco has done. Cisco, through its corporate social responsibility arm, has been working with governments globally across different areas in healthcare and education. Whether it was the US, whether it was in China after the Sichuan earthquake, in Jordan and in India, we have been working with the local governments to provide healthcare solutions to the citizens to help in the case of emergency, as well as post the natural disaster, to continue to build on the services for the citizens. One case, in India particularly, we have been engaging with the governments of Madhya Pradesh and Karnataka. In Karnataka, I want to give an example of our current involvement in Raichur, where we have actually deployed our health present solution. We actually partnered with the hospital called Telerad, which provided the doctors and the patient. We also set up the clinic in Raichur, and as part of that, we had almost like 4 different entities which were part of the solution, from the service provider, the doctors, and Cisco providing the technology to make this relevant for the citizens. The outcome of that has been that the patients themselves are very satisfied with the experience. Now, in order to make sure that this scales in a sustainable manner, all the different entities in the partnership need to have a clear understanding of what the end goal is. You know, whether it's serving the patients at no cost or at some cost. And as you rightly mentioned, providing something for free doesn't necessarily be looked at as value for money, right? So we do want to be able to charge the patient some amount at some point in time for the different consultations. At the same time, the service providers and companies like Cisco need to also make some sustainable business out of it. And so I think the idea is that we have learned that as we go into some of these PPP models, there needs to be a clear understanding of what the success criteria for that particular project is. What are the clear goals that each of the entities will have, as well as the government and the end users, what they're going to take away from it. The other thing, the other thing is also that who does what, right? In a partnership agreement, often what happens is we assume that somebody else is providing the network bandwidth, and does that really get delivered or not? So the governance criteria for the project, how does that get executed? Who is managing it on a day-to-day basis, right? So that also needs to be all figured out. So for the success of the project to happen in a sustainable way, different entities need to work together to define the goals and then look at the sustainable business model for it. The other big piece is about phasing out the project. So even in the case of Raichur, we first started with saying, okay, can we do this kind of in a point-to-point manner? Make sure that the doctors and the patients understand how the telehealth consultation works, and then look at sort of a mesh kind of environment where we have different clinics kind of integrated into a centralized manner. So before we scale the project, one needs to understand that the doctors also understand how to use the solution, the patients understand what they're going to get out of it, and then look at scaling. So using a phased manner to scale the project. So these were some of sort of our learnings. And we have also been involved with IIM Bangalore and a couple of other sort of companies to look at the common service centers where Cisco can also be a participant, and that project is also underway in a few places. So that's all I sort of wanted to start off with, and then we can probably address more in the discussion.
So I come from academic background, so I'm not directly involved with public health, but being a researcher in this, I can tell you the things that I have felt myself, being deep into the government systems, and a person who motivates investors to invest in this so-called PPP model. I hope all of you, as well as the panelists, understand the PPP model. The what business, as you said, carries a stigma, especially health, it carries more stigma, where the profession has been already blamed because the private practice has killed the profession. Fine. So with that background, we are starting this business. So we should understand the basic philosophy why it is not taken up as a business model or business case. Because as you know that many of the people are from industry, they know very well. The business, maximum business you get from home, from government business. Now if you can deny that most of your business come from government, how it come from government? There are policies laid down. Whether it is now the telecom, it is just like a cyclone it is going on, Millions, in this meeting itself you heard 700 million, somebody said 850 million, they're all government statements. You just imagine, even is not 850 million, it's 700 million out of 1.2 billion. So you can imagine, whole world realizes this tremendous growth. And there are so many private companies are getting benefited. Now why you are not making business case in our telehealth? That you have to understand. Because we failed to sell this tool as a business case. So in basic business model, there is a demand. We have failed to create a demand in the public. We have never made the people realize that this is a technology which is beneficial for them. So what we did in all these years, we took place technology first, keeping people in the back, policy in the back. We never addressed those things. We addressed, but we failed. Because we as a society, starting from the 2001, if you see the first presentation from us, we mentioned about making a national issue of telemedicine policy, but somehow the system of governance in this country is such, we somehow failed in our endeavor. We have not lost our energy to do that, but unfortunately we could not do it. And both with due respect to the Space Research Organization and also the Information Technology Ministry, they have played their role to make the technology aware. But ultimately, the users ministry has to come in the picture. And let me tell you, after I gave the information that most of the business you get from government, when did the first budget was allotted to e-health? Do you know what is budget head? I asked all the industry people, did you find out? Did you influence? Did you lobby? Today morning itself, you heard from one of the government functionary that there is a need of lobby. Maharashtra government, the additional chief secretary said these things. We don't have any problem with the money, right? But we failed to lobby it, whoever it is. So we failed in several fronts to address the policy issue, to address the people issue, and to address the payer model and a model for PPP. Whether you invest from CSR or invest from any other source, but somehow we have failed. So now the time has come to keep those issues in the top, in your front agenda. Just a couple of minutes back, I was talking to the president, the current president, Mr. Bedi, who incidentally is belongs to Delhi and stays in Delhi. So I told him, if during your presidency, if you can make this e-health policy document and revive the task force in which you worked for 6 years without taking any consultation fees from government, neither charging or transport cost from different places, please see that it sees the light of the day. So I feel the business case can only happen if you have a government policy. The first, now government has started realizing when they failed to meet the deadline of the Millennium Development Goal. All of you know what is Millennium Development Goal. 2015, we are supposed to meet the deadline. And India is one of these, what you call, third or fourth from bottom. Sri Lanka has achieved many of these things. I was in Iran. Iran has already achieved the goal number 6, number 8 related to maternal health. But we failed in these things. Then next point I wanted to highlight, these are issues I am highlighting. The second issue is, I just referred to that, we failed. Both, I'll say that all of us, industry, academicians, and whoever is in the government agencies, we failed to sell e-health tool as a commodity model. Now you just go and tell e-health, this is the way you consult the physician, it's not going to work out. What I feel, that e-health has to be presented to the public in a different platter, right? We had a good opportunity of the common citizens service centers. And I don't know, do apologies of the government agencies sitting here. We have failed miserably. I have no hesitation to say this thing in front of Mr. Shankar Agarwal. And I am a person who has been earmarked by all the government agencies that I speak in front. Let us accept, we failed. Why you have failed? Has anybody addressed? Now you don't have the horse there, but you are putting a horse cart, right? That means who is a horse nowadays? It's the broadband. Now we are making the broadband policy, right? This is not the case in India. 500 odd millions, the US government has given to this thing, 10 or 11, I think here Dale Averson is there, he will tell you. The 10 or 11 academic centers are given a couple of millions. It's a huge amount by the US government. And Federal Communication Commission regulated this thing at the brainstorming session. Dale Averson during his presidency of ATA, you see his presentation PowerPoint is available in the web. He was so critical. Even in the US, the broadband has not reached. We consider US is the role model, God for us, developed country. So let us address those issues. And all of you know that broadband, the real sense mobile broadband, you talk of M-Health and so, is not reached to the rural area. That is the answer. Government has realized long ago the wide solution is gone. The last mile, nobody talk about last mile nowadays because mobile has taken over the last mile, So now why not to strengthen the mobile, giving this horse, which is a mobile broadband internet. What we want, a consistent, assured bandwidth. Now all of you are using the broadband in different capacities, house, in institution. You are assured with some bandwidth and you see what is the committed bandwidth. What is committed, what you really get it. We proved it and presented it. Again, we are becoming the black sheep. You speak out the truth. Let us shout. We are paying. I have taken 10 Mbps lease line from so and so companies. And I get these things because I monitor it. People don't monitor it, don't realize it. And when don't get this bandwidth, and they have a third party who monitors this thing, and every week they will send a mail, I forward it back to them. Come and check yourself. They don't. We don't ensure those things. Now the issue that I want to highlight is today, the only answer for the 70% people who are living in the villages is to deliver this electronic healthcare in a different platter. Not the M-Health that is being promoted by developed agencies. We don't want anything to be transmitted in a handheld. No, we don't want that. We want the mobile broadband the way that ISRO has shown us the example. Taking in a van, giving all the facilities. Of course, we don't use ISRO bandwidth. We can use this so-called mobile broadband unit. Why ISRO has to spend so much money? Right? Because that time these kind of options were not there. But they have shown, they have proved the concept. It is possible. Right? So now the time has come to have that kind of model if you want to make a business case. And I can only suggest to industries or any consortium who are making business case that first don't start with the initial event, that is teleconsultation. Teleconsultation environment, I am contacting a person who is not known to me. First start business with telefollow-up. chronic disease, diabetes, hypertension, cancer, joint disease, where I am, because most of the times in the private setup, and don't start with government. Again, with due apologies to the government people who are here, I am also from the government. Do not start this business from the government organizations. Start with the local practitioners on whom the villager has a faith. He goes there for himself, for herself, for his family, for his neighbor. So start the business case from there. And practice is so-called wireless health in a different kind of platform rather than following the West. That's what I want to comment.
Hi, my name is Girish. I take care of the healthcare vertical for HP India. And I think talking about PPP, we are doing a small piece of work, a small piece of work with the government of Maharashtra. And I think talking our experience makes it more relevant to the context. You see, the project that we are doing with the government of Maharashtra is basically creating IT infrastructure and network between 19 hospitals and 14 medical colleges in the state of Maharashtra. And it includes entire IT infrastructure, the server, the storage, the network, and also the end user terminals like the desktops, printers, scanners, including the furniture, the chair and the table which they use for computers, and things like that. And also an application on top of it, partnering with Amrita Tech. And we are also creating a training facility as a part of the contract at all sites. And the model today, we have implemented, I think we have done about 5 hospitals as of now, and we are ready to go live in another 3 hospitals. And the lessons that we learn out of it is enormous. One is on the value that you gain out of this kind of work. Second is the financial modeling that we have done in doing this project. And say, for example, once we have implemented this solution, what we have learned is that the hospital generates some revenue in terms of registration charges, some of the investigation charges. It may be nominal, but they do charge patients. And wherever we have implemented, the revenue collection in the hospital has gone up by about 78%. So this is basically the pilferage which was happening, nothing else otherwise. Similarly, the drugs. The biggest problem the health secretary used to talk to me was that, say for example, in JJ hospital, you go around Baikula, you will get not for sale drugs in every chemist shop. It used to be sold. Now today we created a system by which at least about 92% of the prescription, these are system generated reports, about 92% of the prescriptions are generated online. And it gives them very less chance to fudge data at the end of the day in terms of stock management, for example. And we have also gone ahead and done certain things like when we were working out this PPP model, I asked the minister and the secretary that you're investing, it's a 273 crore project for 7 years, and you are investing so much of money. What is the end user benefit out of it? What is the end user, the patient, getting out of it? The patient's waiting time for registration those days when we were talking was about 1 hour, 10 minutes at an average, just to get registered in JJ hospital. The registration counter opens at 8 o'clock and people are queuing up from 6:30. That used to be the case. So he asked me, can you take it and reduce this waiting time as a contractual clause, as an SLA? I said, yes. They gave me an SLA of 20 minutes, but I said, I will do one thing. You will have to outsource the entire registration process to me. As long as your people are doing it, I can't guarantee that. So how do we work out a financial model for that or a business model for that? I said, okay, you pay me for every registration that I do. How much do you collect? You collect about 10 rupees. You give me half of it, I will run your complete registration process with an assured SLA of 20 minutes. In fact, we got a national award last year for bringing it down to 9 to 11 minutes an average time for waiting time for any patient walking in at any time in the hospital. So now what made this 273 crore project affordable to the government? Government was shying away. They couldn't get this kind of funding from the cabinet when they were to approve it. It is the financial modeling that we have done which made it happen. It is not technology, it is not solution, it is not the infrastructure that we created, it is not name HP which made this business work. It made it work for the reason that we agreed on a contract that we will take it on a monthly, you don't invest anything. We will, we will invest upfront the entire infrastructure solution. You pay it on a, we have a two model in it. One is the fixed model, the other one is the transaction model. It's a mixed model, wherein you're paying us on a monthly basis. And initial 1 year was a pilot, so that the government is not running the risk of you creating an infrastructure which doesn't work. Once the pilot has gone live, then only you roll out to the other 18 hospitals. That is the model. So there is a risk mitigation which government has done by doing that, and we took it up. The second thing which we have done is that while doing this entire exercise, we had a lot of challenge. It is not that it is without challenges. The biggest challenge which we faced is that everything is owned by us. Nothing is owned by the government. They are paying for the service. I have about 550, say, terminals lying in JJ Hospital, which has got some 38, 40 acres of land, which is an open thing. And the biggest problem was theft. Simple things. And we went around the country to look for an insurer who will offer me an insurance for it. Nobody. We went and we had to invent a kind of a furniture which will lock the entire piece. Okay, I mean, from technology, we went to carpentry. And we had to design, manufacture, get it manufactured, 500 pieces at each hospital. Furniture which is lockable, everything is lockable, except the mouse. So I lost about 32 of them last month. Okay, so that is the challenge that you face. Now the question is, having done all those things, I personally feel industry has a role to play. We can't, from the industry friends, I would like to say that, we have a role to play. I totally agree that government is the biggest customer for the industry today in India. Nobody else can afford. And that too, in a country where we have such large population. Any populist public delivery system needs to be supported by the government. When we say supported by the government, it is the policy that government can support with maximum, then maybe some creating infrastructure, which is in the domain of the government. It is not in the domain of the private players. So if government can create right policies, right infrastructure, and congenial business atmosphere, which means proper governance, less procedural red tapeism. I mean, like today, if my challenge, the biggest challenge is to get a steering committee organized in the government. The reason is that it has got 5 secretaries. And for the past 1 year, the steering committee is supposed to meet every 3 months. For the past 1.5 years, I'm struggling to get one steering committee organized because I don't get 5 bureaucrats together. I can't get a date from them to have a meeting together. So this is the challenge. And in case if we are able to address that, and the industry role that I want to remind everybody is that we always feel technology is not affordable. Yes, it is not affordable if you don't view it in the right way, especially when it comes to computers, computerization or software, IT infrastructure creation cannot be directly related to a return on investment in a hospital. We are not able to find that. If I'm the CEO of the hospital and somebody gives me 50 crore, the board gives me, the first thing which I'll run to buy is a diagnostic equipment where I can at least show that there is a 3 years break even I can show. But I can't do that when I make investment in IT. So that's a challenge. Now, how do we do that is, I think the industry role is to create newer financial models to make it affordable to others. If you look at the number of people owning car today and 10 years back, it is not the car prices have come down. Their affordability has increased, or there are ways and means they have been empowered to afford more. You go to every car dealer, there is a financier sitting there. There may be a cost of financing, but you don't lose the opportunity to own a car. It is made affordable to you through some other instrument, some other mechanism. I think industry needs to keep on inventing that particular model of business, which will work with government whenever it comes to, because anything to do with mass, there is huge money involved. Nobody can afford it, even government cannot afford it. When I say Maharashtra government was not willing to do it because of this cost, that's the reason HP went and created a financial model of monthly payment system for 7 years. They said, fine, we can do that. Monthly, what is the outage? X amount. Yeah, we can afford that. But can you afford 273 crores? No, I can't afford it. So this is the way, I think industry has got a role to play in terms of, working on this modeling again and again, finding newer business models to get business, at the same time government has to clean up their acts of governance. If these two things are done, I think we are done. Thank you so much.
Good evening, ladies and gentlemen. My name is Sujit Chatterjee. I'm the CEO of Dr. L.H. Hirandani Hospital. And by profession, I'm a gynecologist. And so far, what you've heard, what I've heard, is like going in a Concorde. Now, I'm going to bring you down to a bullock cart. Now, the need for telemedicine was perceived by me when I was a rookie gynecologist way back in 1980, when I was posted in the port city of Visakhapatnam. Now it was, ladies and gentlemen, it was a 400-bedded hospital, and I was the only gynecologist. Now, I just completed my post-graduation, and I was told by my teachers, don't tackle surgery that you don't know. Build your reputation, and then people will come to you. So with that in mind, armed with my textbooks, I landed up at the port city of Visakhapatnam. 2 days later, there was a delivery, which in technical terms is called a precipitate labor. The lady goes into labor very quickly, and the cervix opens up, that's the mouth of the uterus, opens up at an enormous speed, and the baby is suddenly born. Now there's a complication. And that complication is some part of the cervix, that's the mouth of the uterus, can tear, and instead of bleeding outside, you bleed inside. So after the delivery was over, and everything was very happy and the baby was crying, I saw the uterus on one side and another football-like mass on the other side, and I felt the lady's pulse. We didn't have electronic monitoring, and felt the baby's pulse was very, very quick, and the blood pressure was coming down. So I said, yeah, there must be hemorrhage. Don't do surgery that you're not used to. So I took the patient to the operation theater, and I told the anesthetist, but I don't know what to do. So he says, then in the armed forces, and I was in the armed forces, we have senior doctors who are linked, and I wish telemedicine was available. So the closest place was Kolkata. And I ring this guy up in this faint line, and I tell him, sir, this is my situation. He says, damn it, idiot, go and operate. So I said, what do I do? So he told me a very simple thing. The mass is the hematoma. Nick it on top, and all the blood will come out. When the blood comes out, the blood pressure will fall. But don't worry. That you can manage with the anesthesiologist giving blood. The artery which is torn is right on the side, and you will find it pulsating, catch it. Damn good. I told the anesthesiologist, I'm doing it, but you be on the line with this guy. Now the anesthesiologist is a very smart guy. What he did was, he just kept, the phone was down, but he kept saying, yes sir, he's doing this, he's doing that, and the second anesthesiologist got busy with the case. So I did exactly what he's told me. And I found the bleeder, I sutured up everything, and I was hoping that I could speak to the doctor and tell him, sir, I did it. When I went out there, there was a big laugh. He said, damn it, we were talking to ourselves. But the point in case was, ladies and gentlemen, that that little voice was what gave me the courage to go ahead and do it. That, go ahead, do it, damn it. Now, that's what telemedicine would do in our country. Now, there was, a lot of talk about bandwidth and where healthcare is going. Let me tell you, secondary medical care or secondary level of healthcare is most important. Now, we cannot be proud of the fact, ladies and gentlemen, that we have the highest maternal mortality rate in the world. And we cannot be proud of the fact that we have the highest perinatal mortality in the world. Even Pakistan and Bangladesh do better than us. And why so? Because of one reason, emergency services. I was in a discussion with a couple of doctors, and they said, look at the state of Kerala. If you exclude the Bimaru states, We are great as far as maternal mortality is concerned. I said, okay, fine. He says, you know why? Because of the level of education of the woman. I said, great. What about Dubai? Where's the woman educated there? And look at their maternal mortality rates. It compares with Sweden. Now what? So, ladies and gentlemen, the cause is we don't have good emergency obstetric services in the rural centers. And you will have doctors, rookies like me, working there who will kill until and unless they have that little bird whispering in their ear, go ahead, son, don't you worry, I'm right here. And this is what you need to do. So I really felt that if I had somebody looking at me and telling me, hey, son, don't worry, go ahead, it would happen. Now, I think that's the scope of telemedicine which I would bring to the grassroots level. Enormous. Public-private partnerships. The track record in the state of Maharashtra is not very good. We were the first, my team and I, to deliver a hospital to the Navi Mumbai Municipal Corporation on a public-private partnership format. But the role play of the two parties are completely skewered. Ladies and gentlemen, we signed one MOU, and when we were about to implement the project, we had to sign another MOU. Now, you can't do business in this manner. You have to have accountability. So the political will of the government needs to be extremely strong to push a PP3 through. There's a lot of hostility. There's a lot of mutual suspicion. We'll have to get over that. But we can do that. And a business model can be created. Mr. Girish has very rightly said that it could be a new business model which could be fragmented into paying. So we could do what we call collaborative financial engineering. And there are so many things that one can work out. And there are very good models of telemedicine consultations working. For example, Devi does a marvelous job in Narayan Hridalaya. And I was with him. And when he sat and he said, Sujit, why don't you sit with me and I'll show you exactly what I do with the Birla Heart Center at Kolkata. And that was a marvelous experience with ISRO backing them up. It was a marvelous experience for me. And I am a healthcare professional. So therefore, I think I have a small hospital at Thane, and I'm linked to them. And I'm linked just by real-time ECG transmission. It goes straight to the cardiologist sitting in our OPD, and he gives an advice. He says, move this patient immediately for a primary angioplasty and myocardial infarction, or he sees the ECG, he asks the doctor there, what's the condition? If the patient's stable, patient not stable. Patient not stable,